Today's journal club is on one of the important aspect of fetal medicine, that is prenatal screening and diagnosis, especially when we are screening those babies for birth defects or chromosomal anomaly. Especially everyone is doing for screening for the Down syndrome. So what is the current update on prenatal screening and prenatal diagnosis? There are two words. One word is screening and another word is diagnosis. The screening is just like it is a mass screening to get the idea or detecting the baby with the fault, baby with the aneuploidy, baby with the Down syndrome. So the basic screening was age. And before all discoveries of quad marker, ultrasound, whatever it is, people were asking, what is your age? By that age, we might feel that this lady might be having a baby with Down syndrome in her womb. So what is, if we will do with the age, there will be lots and lots of diagnostic procedure and there will be false positive cases. So this detection rate will be very less. So you need some other modalities with age so that you can get more detection of the babies with less false positives. How this evolution happened? This evolution happened because if I go with age, then if age is taken only, then there will be a lot of false positives. Lot of false positive means to identify a Down syndrome, you have to do a lot of amniocentesis, which itself is having its own problem. So it is not a good screening test. If it is not a good screening test, it is just like catching a thief. If you don't know information, then the police makes a sketch and it sends in the newspaper and all. Lot of those who are not culprit also being caught. Not a good screening. So nowadays there is a CCTV camera. With CCTV camera you can identify the face. With that face, less those who have not committed the mistake will be caught. There will be more detection of the actual person. Again, if this CCTV camera becomes more high resolution and colored, then chances of catching a wrong person will be more or less. So the correction will be more to get the actual culprit, actual person who has committed the mistake or committed the crime. Now, if this thing happens, there might be 3 or 4 person might be caught. There might not be anybody in this group who has committed a mistake or did a crime, or there might be one person in that group and others might not be criminal, but they have been caught because of your camera. So there is a detection, but there is a chance of false positives. So it is wrong to give a penalty to innocent person, and it is wrong to absolve the person who has committed the crime. Then what does court does at the end? We take the DNA samples from the criminal scene, crime scene, and then we match this DNA with people who we have caught or police has caught. This DNA matching happens with any person or with no person. If there is no matching, then nobody is criminal. But if there is one person in that group who had committed the crime, will be caught by matching the DNA, because similarity of the DNA, if you take many, at least police take 16 to 21 markers, these markers will not be exactly correct in On this earth, very, very rare that two people will have 16 or 18 or 21 markers similar. So in that group, you will get a actual person caught, actual person will be given the sentence. This screening will be confirmed by DNA test. The same thing happens when we think that all babies, until proved otherwise, are in trouble or might suffer from aneuploidy or suffer from Down syndrome, which is one of the common chromosomal anomaly which takes birth. Next is 18, trisomy 18, next is 13, or there might be X or Y. What happens to the other babies with the chromosomal anomaly? Most of them, they die in utero. So we are worried about those babies who takes birth with chromosomal defect. So there are chances of chromosomal defect with most commonly with Down syndrome. Then 18, trisomy 18, 13 and X and Y. That means we are more worried if it happens in utero, there is an abortion, there is a termination, spontaneous termination, no problem. But if the baby takes birth and you didn't identify exactly by your methods, then it becomes a problem. How to do this screening in modern days so that chances of having baby with abnormality will be less? What is the new guidelines from American College of Obstetrics and Gynaecology? What actually we are doing in our clinic? What report you are getting when you send first trimester screening double marker or second trimester screening quad marker? These words are called screening. You are trying to identify the baby without doing DNA of the baby. But when you do with the DNA, it becomes a diagnostic because DNA matches with the baby and you can find out the problem with the DNA. So this is the basic crux of the talk and basic crux of the DNAs or the fetal screening of aneuploidy or chromosomal defect in first trimester. Previously, it was in second trimester. But with second trimester, things become a little bit late. So we try to make more screening methods which might be early so that there will be less psychological trauma to the lady, if at all it has to be aborted. And there will be a privacy also, because in second trimester when you go, it needs admission and a lot of long things happen. So I am starting with this talk, and in between Ashita is with us. She will ask questions from a common gynecologist point of view. And the prenatal testing is a tool that can be used to detect some birth defects at various stages prior to birth. Prenatal testing consists of prenatal screening and prenatal diagnosis. So the test contains two things. One is screening and another is diagnosis. There are three purposes of prenatal diagnosis: to enable timely medical or surgical treatment of a condition before or after birth, to give the parents the chance of abort a fetus with a diagnosed condition, and to give parents the chance to prepare psychologically and socially, financially, medically for a baby with a health problem or disability for the likelihood of the stillbirth. So basically, we are doing surveys with fetal medicine, the whole fetal medicine. What we practice nowadays is जिसको बच्चा हो तो बच्चा अच्छा हो. They should have a healthy baby because it is irreversible affair. More early you identify, better will be psychologically to the couple. So the cheapest screening tool was maternal age. I again say it is not a good screening method. Then several biochemical markers were studied for the risk of aneuploidy. Ultrasound was used to detect the structural defects. Two parallel paths of screening are biochemical and ultrasound, both ultimately converge. This statement is very, very important. See, This is uterus, and there is a baby inside, and you want to identify or screen this baby whether this baby is having any problem with aneuploidy or chromosomal defect or not. It has a cord which is attached to the placenta. This is the placenta. The screening method first was age. So what is the primary risk factor with the age? You can take it out, there are lists. Second thing is, when we do screening methods, it is just like again different types of method to identify a culprit. So there is a method which is produced, some chemical produced by this placenta goes to mother's circulation, and then we identify with this circulating material, comparing with the normal, and if it is going away from the normal, then we identify how much deviation is there from at the particular gestational age. Now, what is gestational age? Not by LMP. We always try to do gestational age by crown rump length. That means you need an ultrasound at the early stage to know the gestational age. With this gestational age, you can identify different type of chemicals produced in the body of the placenta of the pregnancy, goes into the maternal circulation, and this circulating chemical is deviating from the normal. If it is deviating, then there is correlation with trisomy 21, trisomy 18, and trisomy 13. What are these chemicals? These chemicals are, there are multiple new things are coming, but which is established a placental associated plasma protein A and free beta HCG. This is separate, this is separate. It has a different graph. PAPE has a different graph. Compared with the multiple of median, you can understand at the what particular gestational age it is deviating. With that, you make a table and you can identify or screen for these trisomies. That means there is a lab involved, though it is a chemistry. Now, it has been seen that when we see this baby through sonography, there are a school of thoughts, especially by Kiprios and all, who has made the tremendous contribution to this identification of sonographical features of aneuploidy. The most common we take is that is nuchal translucency, NT. There are other things which are related with trisomy 21 or 18 or 13 with sonography, which gives an idea whether there is a chances of having this or this or this. That means there are two things we are doing in first trimester, that you should know the art of sonography. With this sonography, you can identify some of the features of trisomy 21, but this is again a screening. You cannot say it is due to trisomy 21. So it is again catching a thief by having a good colored CCTV camera. So this is a separate thing and this is separate thing by lab. Now, when we try to catch or identify a culprit, we try to make it fuse sonography with this maternal circulation chemistry, that is PAPE and all, and age. If these three things are then definitely there will be more chances of detecting a actual culprit. So it is called detection rate. More there will be variables applied to identify a baby, the problem, more better will be the detection rate. Why? Because if you identify, there will be more chances when you do amniocentesis or chorion biopsy for diagnosis, the result will be true positive. There will be less false positive. When we apply this sonography with this PAPA and pre-beta HCG with a particular gestational age, again gestational age is CRL. So you have to take the CRL in the center to know the NT, because you have to make an NT with CRL, with gestational age and its thickness. Then make a graph to make whether it is deviating from them, how much it is deviating from the mean. So with that you take a likelihood ratio. Likelihood means the baby is likely to be abnormal. So when we do this sonography with age, with this detection rate increasing, and this is done in first trimester, so it is called combined first trimester screening. Now with this first trimester screening, you have applied a chemistry and with ultrasound. If you can do a better ultrasound, you can identify the other features which might be associated with trisomy 2118, like nasal bone, like frontomaxillary angle, like ductus venosus A wave, or there will be regurgitation of tricuspid valve. These are additional things which helps to identify baby is normal, more chances of having abnormality or not. But basically at present, NT scan, if you can do with the nasal bone, so we can call it NT-NB scan. But if an NB is only absent and others are all okay, then if it is less than 13 weeks, then don't worry too much about this. But if you are worried and you want to confirm it, then chance better to go for a DNA test. That is diagnostic. So this is the first trimester screening. Now I'm go again into this slide. So this is maternal age, and two parallel paths of screening are a biochemical and ultrasound, both ultimately converge. What I have told you, that is ultrasound, maternal age and biochemical test. So this is a combination of test in the first trimester. So what is the genetic counseling then? It is very, very important that for any obstetrician, one thing is very important. Today's obstetrician should know genetics. Otherwise, you can order a test. There will be a report. The report generates a lot of information. Then patient asks you about the interpretation of this information. If you cannot do that, then this test will be of no use. So it is better that the care provider more aware about. There are people who are counseling the couple, but ultimately the obstetrician who is a caregiver should know what to test, how to test, the purpose of the test, what information we will get, and how to interpret that information to the couple, because they are spending with your advice. So there should be a pre-test counseling. There has to be if test, then post-test counseling. So healthcare professional trained in both genetics and counseling families to help them understand and navigate the implications. If you're not able to interpret, take a help of a geneticist. Things will be more easy for the couple and for you. So genetic disorders, there might be chromosomal disorders, there might be Mendelian disorders. What are these disorders? These disorders are, what is a Mendelian disorder? In between, there is another disorder which is called copy number variation. I will come to that. So, but there are The genetic disorder is what he has written, that it is a chromosomal. What is chromosome? The whole DNA is in a thread. Two threads we get, one from father, one from mother. And when this cell divides, these thread is converted into different packets or pieces, so that it can transfer to the next generation through gametogenesis, or it, when it makes another copy, so you can make another copy of this. These are called tetrads. If 1, 2, 3, 4, like 23 pairs, so that means there are 46. If there any abnormality from any chromosome which is extra, then it is called, or less. 46 is euploid. Eu means good. Extra or less is aneuploid. If there is an less, then except sex chromosome, that is X and Y, this baby becomes miscarriage or missed abortion, or it is a missing all growth and it aborts. It is stopped inside the uterus. So we are not too much worried about the less chromosome, except 45X0, that is Turner syndrome. The girl takes birth with this. Otherwise, body cannot tolerate a major loss of one chromosome and it dies in utero very early. But if there is an extra chromosome, the chances of missed abortion or abortion is more. But with extra number of, I have numbered 1, 2, 3, 4, 5, 6, there is 22, 21, 18, then there is 13. So chances of taking birth, not aborting, more common with aneuploidy, with one chromosome from father, one chromosome from mother, one pair as last 23 pairs. This, there are disomy always from two people, mother and father. But if mother gives an extra chromosome, then it becomes, the soma means body, then because the di becomes tri. So it is a trisomy. Now if it is a 21 number extra given by mother, then it is a trisomy 21. 13 given by any parent, trisomy 13. 18, why we are worried about this? Because they might take birth. If baby takes birth, then it becomes a big problem for the couple, for the family. Otherwise, most of the time, this extra chromosome with fertilized egg dies. We are worried about this. So it is a major chunk of chromosome, this DNA pieces which are called chromosome, either extra or less. So these are called chromosomal disorder. Now, there might be some problem with, there are two chromosomes, because we are normal people, we are disomy for every chromosome. That is 1 to 23, we have, for 1 we have 2 pairs, 1 pair, for 2 to 1 pair. So like there are 23 pairs. If 23 pairs are there, then it is called euploid. But what happens if there is a loss which is not visible by microscope, because we see chromosomal analysis do by microscope. If this happens in such a fashion that few of the part of one of the chromosome, either 1 to 23, misses, or there is a deletion, then on chromosomal analysis you will get the full chromosome pair, but actually it is missing here. This part is also having a counterpart here. So this counterpart will be not balanced by this because it is missing. So there are always two copies of each part of the chromosome. When there are two copies, then things goes well. But when there is a part which is not visible through microscope, which is missed, so there will be only one copy. Or there might be, because of some recombination procedure, there might be two copies. So there will be gene overdose because this part contains lot of genes. So this copy which becomes abnormal is very common more than chromosomal defects. So these copy number variation if it takes place in that of the chromosome where very important genes are present to look after your day-to-day activity, then there will be defect in the protein production. If it is an enzyme, then you will be in trouble, the baby will be in trouble. This is more common in population other than aneuploidy. Euploidy is 46, aneuploidy is more than 1, 46, 47 or 45. This is more common because it is not visible in microscope when you see the chromosome, because it is visible in microscope. Because it is not microscopically visible, so it is called submicroscopy. When it is submicroscopic, there might be deletion, it is absent, then it is deletion, or there might be two extra because of recombination or any event. There will be duplication. So this is again, if it is not containing an important gene inside that, no problem. So all micro deletion and duplications are not disturbing. But those submicroscopic deletion and duplication which carries very important gene may have same effect or like effect of chromosomal defect. This is more common than chromosomal defect. When this happens, then why we are worried about this part? Because it is not related with the maternal age. That means microscopic deletion and duplication can happen in any maternal age. Even though trisomy 21 might have in any maternal age, but maternal age, if you see a graph, then this Down syndrome goes like this after 30. So there is an age-related increase in incidence. But with submicroscopic and deletion and duplication, the maternal age is not related with this. Second, it is sometimes 1.5% of the population it is happening. They may be pathogenic or may not be pathogenic. But if there is a problem, any part of the baby in ultrasound, then there are chances of submicroscopic deletion and duplication will be 1.5% to 1.7%, quite high. And Down syndrome overall is 1 out of 400 to 500. So if you see, this is 1.7 per 100 and it is 1 in 400, definitely its incidence is more. It is not related with the maternal age. That means it happens maybe in younger age also. That means, so we are all worried about this part also. This is common in fetus, more common than incidence of Down syndrome. So we should not always go behind only for Down syndrome. There are more submicroscopic deletion duplication syndromes. I'm not going into that, but DiGeorge syndrome, Prader-Willi syndrome, there are a lot of things which are very problematic, rather more than Down syndrome. So we have to take a look after this also. Third, what is given is that Mendelian disorder. Now, what is Mendelian disorder? Mendelian disorder is we get one part, one chromosome from mother, one chromosome from father. And suppose my father contains a gene which makes globin or beta chain of globin of hemoglobin, and my mother is having a beta chain at the same place. So this part of the chromosome which contains part of the DNA, part of the whole DNA system, which creates or manufactures beta globin. So I have two alpha gene and two beta globin gene, protein. Now this protein is made by this gene. So we have one beta, two, one. Now, if my mother is having some problem with this beta globin gene, which creates, suppose it is such a long amino acid chain and it creates like this. So this will not create a good beta chain for the beta 2 part or beta 1 part. So there will be problem in. Now, when in family, suppose this is the female and this is male. The male is having normal beta globin gene and the female is having abnormal beta globin gene. They create gamete, then there might be combination of this. So there will be both abnormal, no beta globin gene. No beta globin gene means no normal hemoglobin. That means hemoglobinopathy. No hemoglobin, good hemoglobin means difficulty in oxygen carrying capacity. So there will be anemia. So this is called beta thalassemia. There will be more hemolysis, so it is a hemolytic anemia. Now, if this combines with this, I'm not going into that, but this combines with this, there will be an abnormal and there will be normal. So there will be some beta globin. So there will be beta globin or thalassemia carrier. They have one normal beta globin, another beta globin, suppose 0. So this is called thalassemia carrier, beta thal carrier. If this and this, the baby will be fine. And if this and this, the baby will be carrier. Now, today I did an amniocentesis where both partners are diagnosed by HPLC that they are having HbA2 or they are beta thal carrier. Again, beta thal carrier, and they want to reproduce. And there is a pregnancy. If this is the case, then there will be, baby will take birth with a genetic disorder with beta thalassemia, disaster, problem. This might happen with all genetic disorder. This genetic placement and its passage to the next generation takes Mendelian law. It follows mostly Mendelian law of independent assortment, law of dominance and all. So the genetic disorders which are present in either of the parent, when we identify in the baby, we diagnose the Mendelian disorder. So my goal is having a healthy baby. No aneuploidy, no submicroscopic deletion and duplication, and avoiding any genetic disorder where the husband-wife is a carrier. So whole fetal medicine is finding out the disease in baby so that there should be a good outcome after the pregnancy, getting a good baby. Now I go again into this. So this Mendelian disorders, in human, Mendelian disorder is a type of genetic disorder primarily resulting due to alteration in one gene or as a result of abnormalities in the genome. Such condition can be seen since birth and be deduced on the basis of family history using the family tree. We have to make a pedigree. Certain populations are increased risk of specific disorders, but this did not rule out the presence of specific disorder in other population as well as occurrence of, because if you marry more in close community, more chances of carriers getting married. So in few communities, there are high chances of those Mendelian disorders which are rare. But if it is close community, we have to find out how many of them are carriers of those diseases which are common in that community. So with ethnicity, we can make a carrier screening. Nowadays with IVF and all, we do carrier screening also. I already told this is the chromosomal disorder, the whole chunk. Chromosomal abnormality, aberration, mutation, disorder, missing extra or regular portion of chromosomes. This can occur in the form of numerical or structural, but it is visible in microscope. Chromosome mutation was formerly used to strict sense mean a change in a chromosomal segment. Increasing age of women getting married and having the first child has increased chromosomal disorder risk. But there is a dramatic difference of acceptance of genetic risk between 35-year-old multipara and a primipara. This statement is very important because nowadays, previously it was found that the primipara was 18 or 23 years old. So less chances of getting down baby. So not very much worried. Nowadays, the primary is 35 years old. Already age matters. So there will be more chances of Down syndrome. So there is a difference nowadays. So we are more worried about those cases where the pregnancy is taking place in the later part or little bit higher age. But is Down syndrome is the commonest birth defect? No. The commonest birth defect worldwide is heart defect, neural tube defect, then hemoglobin disorders, then fourth number is Down syndrome. So we should be more worried about heart defects while doing the ultrasound, do a fetal cardiac screening more often and more intelligently. Neural tube defects, we should see the neurosonogram also. Hemoglobin defects, we should identify the carriers. I always do and always propagate, please do at least HP hemoglobin electrophoresis as a primary investigation. Glucose 6-phosphate dehydrogenase deficiency. This is the Down syndrome, and I already explained about that. What is that? Shifted from second trimester quad marker and ultrasound to the first trimester marker anti-scan, better ultrasound apparatus. This is also very important. You should have a good machine and you should have a good training also, and strictly follow the guidelines. If you follow the guidelines, you can detect more babies with Down syndrome, but everything is so disturbing in our country is that there are so much load in OPDs in this government setup or with a good practice. Following these things might be difficult, then take a help from your colleague who does these screening with guidelines. But if you follow the ISWA guidelines or FMF guidelines, your chances of missing the things will be less. and how the evolution of Down syndrome screening occurred. Now there is, if you take only the maternal age, sensitivity is very low, high amount of false positive. Then low maternal serum alpha fetoprotein plus age, that is alpha fetoprotein component, 1980s 50%. Double marker, that is in second trimester AFP and HCG, 1990s 55. You see the sensitivity is increasing because you should not catch an innocent person. There should be a good detection of the actual culprit, actual person with this disease. Then there is a triple, there is a quad. Gradually it goes into first trimester with nuchal translucency. Again, everything changes from chemistry to machine, that is ultrasound. Now it becomes a subjective thing. If you do it in a proper way, the sensitivity is 60%. Now if you combine it with the free beta HCG and PAPE and NT, suddenly it goes from 60 to 85% because you are combining with the lab also. Then there is a sequential method which is not used nowadays. Another very important feature came in market is fetal DNA, which I have not touched yet, but I will do that later on. It shows it is a 98% sensitivity, but 98% sensitivity doesn't mean 98% positive predictive value. That means it doesn't mean that it gives 98% chance that actually the baby will come with Down syndrome. Why it is so, I will come to it. It is non-invasive prenatal testing, better to call non-invasive prenatal screening. I am not going into this detail, but I will come to it because it is one of the very frequently used tests nowadays as a primary screening, but there are problems with NIPT, or it should be called NIPS. Why it is so, I will come to it. Low false, one of the advantage NIPT which allows pregnant women to avoid invasive test. This is given, but there are chances that don't take your decision with NIPT results. NIPT might be having good detection rate, good sensitivity, but it is not diagnostic. More the age is less, more are the chances the result will be wrong. So if a 26 years old lady gets an NIPT positive, the chances of having wrong result only for correct result will be 53%. And if you take a decision on that, it will be a wrong step. So it is, again, nuchal translucency is a powerful marker, but it is an ultrasound. And for that, you have to learn ultrasound. You have to follow the guidelines. Then only you can correlate with the likelihood ratio of having with age, with maternal analytes of pre-beta HCG and PAPE to give a good result, good detection rate. Good result and good detection rate means if you say it is negative, then it should be negative. If it is positive, then there should be more chances of positive when we do actual DNA test, that is diagnostic. So these are all which chromosomes, because these chromosomes, with that the baby might take birth. And this is the table what happens with the MSAFP beta HCG history in the quadruple test. In primary, in first trimester, what happens with beta HCG in trisomy, and why it happens, there are multiple theories. I am not going into that details. Why there is a change in beta HCG in trisomy 21 is increased, it is decreased 18 and normal. What happens with the placental cells with these type of trisomies? Because these are all placental chemicals. So prenatal diagnostic procedure, most screening test gives an estimated risk of genetic disorder or confirmation. Invasive testing is mandatory. So we do amniocentesis. Today I did an amniocentesis because amniocentesis I do frequently for aneuploidy screening, which are high risk found to be various practitioners. This can be done. I am trying to do by Korean biopsy in 3rd month also, so that there should be a better chance of getting the result as early as possible. So better to do a one-stop test, that is ultrasound, your maternal analyte, and immediately if there is a high risk, do CVS. The results are mostly we do by 16 weeks, and it takes 7 days at least to do 5 chromosome, and then early amniocentesis should be avoided. How it is done? So there is a genetic diagnosis, indications, therapeutic uses, fetal length maturity. It is in the later part of the pregnancy, intrauterine infection. We do amniocentesis for intrauterine infection, RH isoionization, decompression in polyhydramnios, twin-to-twin transfusion syndrome to release the pressure, preparation for stem cells. This is very important. What I do frequently, that is in 3rd month of pregnancy, 12 weeks, better to avoid early CVS. So it might create problem, and it gives a result of 98 to 99% corresponding with the amniocentesis, but there are 1 to 2%, 1 to 1.5% of discrepancy or mosaicism in chromosomal anomaly, mosaics in CVS. So CVS I do nowadays with transabdominal method. It is done under ultrasound guide, and nowadays I do under sedation or anesthesia, so that patient should not have any problem. You have to take the villi with negative pressure in a hyperonized tube, then see those villi clear from the maternal decidual cells, and then do the chromosomal anomaly and some microscopic deletion duplication. And if it is being done for the detection of Mendelian disorder or genetic disorder, do the genetic test or mutation diagnosis. Prenatal testing by trimester, the 2nd trimester, it is a summary of the tests we do perform in 1st trimester, 2nd trimester, or the 3rd trimester. This is pre-implantation genetic diagnosis for, mostly it is useful for genetic disorders, but nowadays there is PGTA also called when we do IVF. Either you do a trophectoderm biopsy or non-invasive test, that is a spent media. Don't touch the embryo and take the fluid. Mendelian disorder identification is PGT-M, and PGT-SR is structural rearrangement in the chromosome which creates abnormality. May not be in baby, but future baby might be having, or there might be some missing part of the chromosome which contains important genes in that breakage points. So this is a PGT indications, and I am not going into that details, but these are the modern, this is not prenatal. We have gone up to doing IVF, make embryos, identify those embryos, and then do the embryo transfer. So there are a lot of things happening, and at present what we are doing PGT-M and PGT-A mostly, but PGT-A by NIPGT. So it is a planting an embryo which might be disease free or aneuploidy free. That doesn't mean that if there is a genetic diagnosis, there is a genetic identification of the PGT-M, you have to confirm in early pregnancy by CVS or by doing amniocentesis. The chances of abnormal or a genetic diseased baby will be very less, but we must do the confirmation. Thank you very much. Regarding this, and chala gaya. I think the pen is also finished by teaching the longer way. NIPT, if you do it in your day-to-day practice, please don't do NIPT for those cases where there is a high risk for aneuploidy in double marker and anti-scan or combined first trimester screening. Because NIPT is not a confirmatory test, it is again a screening test. And if NIPT comes negative, then you cannot say that pregnant couple or pregnant lady that everything is okay. If you do an NIPT, if it comes positive, then again you have to do a confirmatory DNA diagnosis. So my view is better to do a confirmatory DNA diagnostic test in all cases where the primary screening gives a high risk result. Second thing, we see that in aneuploidy is common, Down syndrome is common, but likewise Down syndrome, there are multiple defects which are some microscopic deletion and duplication, copy number variation, which are as dangerous as or lethal as they might create developmental delay, learning disability, cerebral palsy, autism, peripheral myelin disease, or many problems, heart defects, which are some microscopic deletion and duplication, are much more common than Down syndrome. Down syndrome is 1 out of 400, but deletion and duplication is 1.7%, 1.5%. We say that 1 out of 250 is less. If it is 1 out of 250 in our combined screening, we do go for invasive test. So we take a 1 out of 250 as a limit. But if you see deletion and duplication, this is more common, rather 1 in 50 or 1 in 100. Then what we should do? For that, the American College of Obstetrics and Gynaecology has categorically announced that all pregnant women should be given a chance or advice for invasive test, whosoever they are, what might be their age, because there are cases where first trimester screening was normal, low risk, ultrasound low risk, even though there might be a chance of Down syndrome. Ultrasound is normal, low risk first trimester, there might be deletion and duplication, micro deletion and duplication syndrome. So all patients are nowadays in many parts of the world given an option for invasive test. They refuse, no problem, but should be given, because you cannot identify these micro deletion and duplication, which is more common than Down syndrome and all, with these type of screening tests. If they give an idea during ultrasound some problem, then definitely we need a diagnostic test. Third, any diagnostic test which is being done either through Korean biopsy or by amniocentesis. If it is done for aneuploidy, we should see aneuploidy for 5 chromosomes, that is 21, 18, 13, X and Y, plus very importantly, all invasive tests should have copy number variation test also. Because if you miss the other animals which might attack you, you can count the tigers only, and without your ammunition you go to the jungle. Diagnostic test, when we take the DNA of the baby through amniotic fluid or through Korean villus sampling. Thank you very much for patient listening.